I'm David Albert. I'm a professor of dentistry at the Columbia University College of Dental Medicine. I'm also a practicing dentist, and I've been practicing dentistry since the early 1980s when I graduated from dental school. I'd like to talk about tobacco, specifically tobacco cessation, and what you should be doing as a dentist to assist your patients in quitting. I'll talk about a patient that I saw in my early clinical career named Betty. Betty was in her early 40s, presented to my clinical practice with a request to improve the aesthetics in her mouth. The aesthetics were, quite frankly, poor. She was not happy, and she wanted them replaced. And as a young clinical dentist who thought I knew everything, I was going to make it much better. I took a look at her periodontal health, determined that she had moderate periodontitis with some severe localized periodontal lesions. I referred her to a periodontist to deal with the moderate to severe periodontitis, and the clinical result was exceptional. She also started to maintain her oral hygiene quite well, and I felt that I had a good foundation for creating a prosthetic treatment plan. The aesthetic result was fantastic. I was thrilled as a young dentist, and she was very, very happy. I didn't see her again for about 10 years, and I was taking a look at what was being presented to me clinically, and she was unhappy with the aesthetic result in her mouth. And as I'm looking at it, and I hadn't seen her in a while, I'm saying, this really isn't good. I'm not impressed with what I'm seeing here, and I was about to tell her that I thought it was necessary to replace it, and I realized as I opened up the chart, I was the dentist who put those crowns in place. Why was this such a bad clinical result? What went wrong? Well, now she's in front of me, and she's still smoking 1 pack a day, and she's been smoking 1 pack a day for 20 years. And the ravages on her periodontium were quite apparent, and I had missed it in the 1980s. Now, frankly, I missed it at that point because we didn't have the association between smoking and periodontal disease. We had the association between smoking and oral cancer. But in the 1990s, we had substantial information about smoking and its impact on the periodontium. In 2004, using that same research that was developed in the 1990s, the Surgeon General declared that smoking was a causative factor for periodontal disease. So what did I do wrong? And what can you do in your practice to improve how you deal with patients in terms of prosthetic treatment plans, periodontal treatment plans, placing implants, extractions, all of those? Smoking has a significant impact on the oral cavity. If you don't deal with it, you're going to make the same mistakes that I made. So how do we deal with it? It's not sufficient just to ask a patient, do they smoke, to advise a patient to quit. You need to assist the patient with quitting and arrange for quitting. Assisting means writing a pharmacotherapeutic prescription for an aid, a drug, to help the patient to quit smoking. Arranging means sending the patient to a quit line. So if you don't want to make the same mistakes that I made, deal with smoking and quitting and assist and arrange and help the patient to quit. This is David Albert from Columbia University, hoping that you take this course and that it helps you to assist and arrange with quitting with your patients.